Oh, thank you so much, sir. Thank you.
Okay, thank you very much. Good evening. Good afternoon, senior colleagues and colleagues. I'll be taking a presentation on anatomy of the coronary circulation, normal variants and anomalies. So I'll follow this outline. By way of introduction, the heart is a muscular four-chambered organ that is responsible for distributing blood throughout the body. Its continuous activity creates a large demand for nutrients to be delivered to the cardiac tissue itself and for waste products to be removed. However, this organ has several layers of thickness, and it's therefore not feasible for tissues to be obtained, for nutrients to be obtained via any form of cellular transport mechanism that passes as blood passes through its chambers. It is therefore important to maintain optimum, in order to maintain optimum cardiac performance and homeostasis, therefore, the heart has a network of blood vessels, which is known as the coronary vessels. Thank you. Next slide, please. The coronary circulation consists of blood vessels, that is, it includes arteries and veins that supply nutrient-rich blood to the myocardium and drain wastes away from it. The whole of the human body, and most especially the brain, needs a continuous supply of oxygenated blood, and this requires the heart to function. This is required for the heart to function continuously. However, coronary circulation is not continuous, rather it cycles. The circulation reaches a peak in diastole and decreases almost ceasing during this systole. In other words, the myocardial tissues receive its perfusion during diastole, and that's why it's very important to reduce the heart rate in most patients with tachycardia so as to allow for adequate perfusion. Interruption of the coronary circulation can easily cause myocardial infarction, and thus a basic understanding of the coronary anatomy is very important. So let's look at the origin of the coronary arteries. The word coronary arises from the Latin word coronarius, which means belonging to a crown. This is because when viewed in cross-sectional view from above, the coronary vessels resemble a tilted or inverted crown that is wrapped around the root of the great vessels. So the coronary arteries arise from the root of the ascending aorta. The aortic valve, as we all know, has three semilunar cups, above which we have dilatations known as the aortic sinuses. So the coronary arteries arise from this aortic sinuses. So we have three main aortic sinus. We have the anterior aortic sinus, which gives rise to the right coronary artery. We have the left posterior aortic sinus, which gives rise to the left coronary artery. And then the third sinus, which is the right posterior aortic sinus, which lies just above the posterior aortic cups or the non-coronary cups does not give rise to any vessel under normal circumstances. So this is just a diagrammatic view of what we just discussed. So this is the aortic valve. We have the right, the left, and then the posterior or non-coronary cups. Just above it, we have dilatations known as the aortic sinuses, from which the coronary arteries arise. So we have two main coronary arteries, the right coronary artery and then the left coronary artery. So the right coronary artery, arises from the right coronary cups, sinus above the right coronary cups, and it arises at a perpendicular angle. It arises perpendicularly to the sinus, unlike the left coronary artery that arises at an oblique angle. So this is the right coronary artery here, and this is the left main coronary artery and its bifurcations. This is the pulmonary valve, mitral valve, and then the tricuspid valve and their leaflets. Next slide. So the major divisions of the coronary arteries usually travel just below the epicardial layers of the heart. However, their branches may become deeply embedded within the myocardium as they pass through the cardiac grooves. So coronary vessel branches that remain on the surface of the heart and follow the sulci are known as the epicardial coronary arteries. The proximal end of the coronary arteries usually range between 1.5 to 5.5 millimeters in diameter. But the left coronary artery is typically larger than the right in most normal instances because of the demand by the left side of the heart. So let's look at the left coronary artery. We have the left main coronary artery, which is usually of a larger caliber than the right coronary artery. It emerges from the left side of the base of the ascending aorta, and its opening lies on the dilated wall of the ascending aorta, just superior to the left semilunar cups of the aortic valve. So it's approximately about 5 to 10 millimeters long, and it runs posterior to the pulmonary trunk, just in between the pulmonary trunk and the left atrium. Immediately it emerges, it bifurcates to form the left anterior descending artery, which is also known as the anterior interventricular arteries, and the left circumflex artery. We have some variants in some individuals in which there is a third trifurcation known as the intermediate artery, which is an anatomic variant that arises from the bifurcation in few cases. So the left coronary artery supplies the left atrium, the left ventricle, and the interventricular section. Next slide. So the first branch of the left main coronary artery is the left anterior descending artery. It's actually a continuation of the left coronary artery after it gives off the left circumflex branch. It is viewed as a cauda, okay. It travels inferiolaterally within the anterior interventricular groove to the apex of the heart, and then it passes through the inferior interventricular groove and crosses to the base of the heart. It have septal perforating branches that supply the anterior and the apical septum. The first septal perforating branch usually supply the atrioventricular bundle and then the proximal left bundle branch. It is more often than not covered by bridging myocardial fibers, as well as sections of the great cardiac veins. We'll see later that the left anterior descending artery and the great cardiac veins run along the same course. At the apex, it's anastomosis with the posterior descending artery, which is a branch from the right coronary artery in about 70 to 80% of individuals. So the left anterior descending artery supplies the major part of the heart, usually the anterolateral part of the myocardium and the anterior two-thirds of the interventricular septum. Next slide. So it gives off some branches. It gives off basically two main branches, the diagonal branches and then the septal branches. So branches, the diagonal vessels are usually named successfully from proximal to distal. We have the left anterior descending diagonal. First branch is D1, second D2. Usually we have two main branches, diagonal first and second diagonal branches, but in some individuals, it may be more than that. The proximal LAD is defined as the area of left anterior descending artery between the origin of the LAD and the distance between the LAD and the first diagonal branch is usually referred to as the proximal LAD, while anything after the first diagonal branch is distal LAD. So for septal perforator branches, they usually arise perpendicularly from the left anterior descending artery, and they penetrate into the myocardium via the interventricular septum to supply both ventricles. Next slide, please. Thank you. So this is just a diagrammatic view showing what we just explained. This is the left main coronary artery. It's usually branches immediately. It supplies the left circumflex artery and continues as the left anterior descending artery. So the left anterior descending artery gives off, we have the diagonal arteries, left anterior descending D1, this is the first diagonal branch and this is the second diagonal branch. Then we have the septal branches that run deeply into the myocardium. The left circumflex artery, as we'll see, it courses along the lateral wall of the myocardium. So this is the right coronary artery. Next slide, please. So for the left circumflex artery is the smaller branch of the left anterior descending artery. It courses along the left parts of the atrioventricular groove, along the left atrium and left ventricle within the epicardial fat part. It then loops around the left heart border onto the inferior lateral surface of the heart. It usually terminates within the coronary sulcus before reaching the interventricular groove in a significant percentage of individuals. It supplies the inferior lateral wall of the left ventricle. It also gives off some branches. We have anterior branch, lateral branch, and the posterior branches to the left atrial wall. So the anterior branches are usually 3 in number. It also gives off 3 obtuse marginal branches, which are also designated as obtuse marginal 1, branch 1, 2, and 3. These branches follow the left margin of the heart to supply the anterior lateral wall of the left ventricle. So the left circumflex may pass beyond the crux of the heart and then turn toward the apex to become the posterior descending artery in 25% of cases, in which we refer to it as the left dominant circulation. Next slide. So anatomic variation of the left coronary artery may include, there may be variation in length differences. We said the length is usually between 5 to 10 millimeters, but In some individuals, it may be longer than that. You may have variation in the angle of bifurcation of the left coronary artery. It usually bifurcates. It usually arises at an acute angle from the left aortic cups. And then in some cases, there could be complete absence of the left coronary artery, in which case it arises directly from the ascending aorta. So we've discussed the trifurcation, in which we have the artery intermedius instead of just two branches of the left coronary artery. Then it may also originate from the posterior aortic sinus, which, as we've mentioned earlier, doesn't give rise to any coronary vessel. It may also originate higher from the ascending aorta or from the brachiocephalic trunk. So these are the variations that may be seen in left coronary artery anatomy. Next slide, please. Next slide, please. Okay, so the right coronary artery is the other main coronary vessel that supplies the heart. It originates from the anterior aortic sinus, just superior to the right coronary cups of the aortic valve. It then descends inferior-laterally, where it joins the right atrioventricular groove. From there, it continues around the right cardiac border, crossing from the anterior to the inferior surface of the heart. From the margin, it continues towards the crux of the heart, where it terminates to give rise to one or two terminal branches. So the terminal branch is usually the inferior interventricular artery. It is also known as the posterior descending artery. It may also give rise to the inferior lateral branch. So when it gives rise to the posterior descending artery, it's known as the right dominant circulation in this case, which is usually seen in about 60 to 80% of the population. It mainly supplies the right atrium and the right ventricle. The branches of the right coronary artery can be divided majorly into three groups according to their locations. We have the anterior, the marginal, and the inferior groups. Next slide, please. So for the anterior group, we have the coronal branch, which is the first branch to arise from the right coronary artery. It runs between the base of the conus arteriosus and the superior part of the right ventricle. So after giving off the branch to the coronal branch, it also gives rise to the it gives a branch to the sinoatrial node, anterior atrial, and anterior ventricular branches, which supply the SA node as well as the sternocostal aspects of the right atrium and the right ventricle, respectively. So the SA nodal branch will supply the SA node. The anterior atrial branch supplies the right atrium, while the anterior ventricular branch supplies the right ventricle. So the marginal branch of the right atrium, after giving off the previously mentioned anterior continues along the atrioventricular groove to with the marginal inferior surface of the heart. It gives rise to the atrionodal branch. And then we have several small inferior atrial and ventricular branches that may also arise from at the inferior surface surface of both the right atrium and the right ventricle. So it may also give off the inferior interventricular branch as its which is the crux of the heart, which is the terminal branch usually at the inferior surface. Next slide, please. So this is a diagrammatic view showing us the right coronary artery as its this is the SA nodal branch. The largest branch or continuation is the acute right marginal artery. After it gives smaller branches, the SA nodal branch, and the other smaller branches may passes along the inferior surface of the heart and of the heart, where it gives a posterior descending in cases of right dominant circulation. Next slide, please. And right coronary artery, the aortic sinus, just as the right coronary artery also originates from the right coronary right aortic sinus. Sorry. So in this instance, it is referred to pre-infundibular artery. So in such patients where they have patients that have the third coronary artery occlusions of the primary coronary vessels, there will still be adequate or near adequate blood supply to the right side of the heart. That artery, which may originate from the aortic sinus circumflex artery instead of originating from the as a branch of the RCA. So also the AV nodal and the inferior may arise from the left artery, from the left circumflex artery, the left and the right coronary artery in case of. Next slide, please. So the posterior descending artery, it's very important because this artery determines the dominant circulation. It's also known as the posterior interventricular artery. It's usually a main branch. It's usually the terminal branch of the right coronary artery in about 85% of individuals. But as we've mentioned earlier, it could arise from the left circumflex artery in like 15 to 20%, in which case we refer to them as the left dominant. So it descends in the posterior interventricular groove before coursing along the base of the heart to anastomose with the left anterior descending artery at the apex of the heart. It may give off perforating interventricular septal branches. And this posterior descending artery supplies the diaphragmatic surface of the heart, basically. So in addition, the right coronary artery supplies, it's important to note that the right coronary artery supplies the SA node in 60% of individuals. That's the SA nodal artery. However, in some 40%, this SA nodal artery arises from the left coronary circulation. The AV node is also supplied by the right coronary artery in 90% of individuals. Next slide, please. So this is just showing us the posterior descending artery, as it arises as the terminal branch of the right coronary artery after it passes the crux of the heart. Next slide, please. So clinical correlation of the right coronary artery. The right coronary artery usually supplies the AV node, as I've mentioned. So in case of inferior wall infarction, because we've mentioned that the right coronary artery also supplies the inferior and diaphragmatic surface of the heart. So because it supplies the AV node in 90% of individual, inferior wall MI is usually associated with heart block, variable types of heart block. So also, in 10% of individuals, the AV node may be supplied by the left side of the heart. So if we have heart block in patients with anterior wall MI, it's usually a severe, it has prognostic implication. That means it's a severe infarction. The right coronary artery also supplies the right ventricle, and hence problems relating to a right ventricular infarction are commonly associated with inferior wall MI. That's why whenever we have inferior wall MI, it's important to check and to confirm if there is right ventricular wall involvement. So the posterior descending artery, which is usually a branch of the right coronary artery, in case of occlusion of the posterior descending artery, what we have is usually posterior wall myocardial infarction, which is represented as a dominant R wave in V1 and ST depression in V1 to V4 on ECG. It's just like reciprocal of what you see in anterior wall MI. After turning the ECG, it will show features of anterior wall MI. Next slide, please. Sorry, this slide is supposed to have come earlier while discussing the left main coronary artery. Next slide. So coronary dominance refers to which vessel gives rise to the posterior descending artery. In right dominant circulation, the posterior descending artery is supplied by the right coronary artery. And this is seen in 80 to 85% of cases. While in left dominant circulation, okay, we've mentioned this earlier, it's supplied by the left circumflex artery. And we could have instances in which both vessels, both the right and the left, contribute to the posterior descending artery. In this case, we refer to them as codominance, and this is seen in 10 to 20% of individual. This knowledge is very important, especially in before cardiac surgeries, probably in patients that have myocardial infarction before going in for surgery. Next slide, please. So let's look at the ECG localization of coronary arteries. So this is just a schematic view of the hearts and the way ECG leads are arranged in relationship to the coronary vessels. So we have V1 to V6. As we all know, V1 to V6 are usually the chest leads. V7 to leads that we used they are the posterior leads, while the instances where we are suspecting right ventricular infarction. So this is showing us the relationship between the vessels and the ECG leads. Next slide, please. So on ECG, the lead 1, we all know that lead 2, 3, and AVF, usually that's the inferior leads, represent the inferior leads, and it depends on the supply. As we've mentioned earlier, in the major proportion of individuals, the right coronary artery, it usually supplies the inferior or diaphragmatic surface of the heart. But in some individuals, the left circumflex artery, it's the main artery supplying the inferior leads. So whenever we have changes in the inferior leads, it's either of those two arteries that is involved, either the right coronary artery or the left circumflex artery. For the high lateral leads, that's lead 1, AVL, V5, and V6, the main supply is usually by the left circumflex artery or diagonal branch of the left anterior descending artery in some instances, while V1 to V4 represents the anterior septal leads. And whenever there is problem in this area, it's likely to be the left anterior descending artery that is involved. Next slide, please. Okay, this is just a summary of what's we've seen on the ECG. The only addition is that in posterior wall myocardial infarction, in addition to the changes on the inferior leads, you could have, there's usually a tall R in V1, which is also as a result of right coronary artery occlusion, usually the posterior descending artery involvement. Next slide, please. So this is just a summary of the algorithm. Usually the confusion is in inferior wall myocardial infarction. Is the occlusion in the right coronary artery or the left circumflex artery? So once there is SC elevation in the inferior leads, the next thing to do is to do a right-sided chest leads. In the absence of right-sided chest leads, we can just quickly look at the SC elevation, the difference in SC elevation between lead 2 and lead 3. If the SC segment is more elevated in lead 2 than lead 3, because lead 2 is usually represents more of the left side of the heart, that means the left circumflex artery is likely to be involved. While if the SC elevation in lead 3 is greater than that in lead 2, the right coronary artery is more likely to be the culprit of the inferior wall infarction. However, if we have depression, if there is ST depression in lead 1, it's obvious that it's likely to be right coronary artery involvement and not the left circumflex artery. So for the right coronary artery involvement, we can further would further like to know if it's due to proximal RCA occlusion or a distal RCA occlusion. Normally, we expect V1 inverted T wave in V1. So whenever there is inverted T wave in V1, it's likely to be left circumflex artery occlusion. But once we have, from the algorithm, if we have lead V4R, if you're looking at 4, once there is T wave inversion in lead V4R, it's likely to be left circumflex artery occlusion. elevation with an upright T wave in V4R, then it's likely to be as a result of RV infarction, which is due to occlusion. Well, if there is no ST elevation, right T wave we have without ST elevation in V4R, then the RV infarction, it's likely to be a RCA occlusion. I don't know if it's clear.
Sorry,
Algorithm.
Sorry, Dr. Zakia, this figure 4 you are referring to, is it lead V1 that you want to make this
Yes.
analysis on? This proximal distal, okay, lead V1, right?
V4R, right-sided V4.
Okay, it's also inverted. It appears as negative lead.
Sorry, if ideally, if we have inverted inferior wall, the right-sided lead. So once we have ST elevation in V of RV wall infarction, that's the first two. That's what the first two is telling us. Once we have we have RV infarction, but once the T wave is inverted, there circumflex artery occlusion and not.
Yeah, I understand all that. I'm saying,
Yes, ma'am.
this ECG, is it representing lead V1? Which lead specifically are you to look out for this changes to differentiate whether it is the proximal distal or L6? Which lead?
V.
It looks like V1, but I want to confirm.
Okay.
Do you understand my question?
I understand.
Okay,
Yes.
I just want to confirm which lead are you supposed to be making this. It seems to be lead V1, but I want to be sure so that I don't make assumption.
Okay, I thought it's V4R, but it's clear now. I will check it up later.
Okay. Okay.
Of the house also can contribute. Thank you for the contribution. So next slide. So for there's also this algorithm I came across as to delineate whether the left anterior descending artery occlusion is proximal LAD or distal LAD. Anterior wall MI, we have ST elevation extending from V1 to V4 or even up to V6. It's likely to be LAD occlusion. The next thing to do is to check for the ST leads. Once we have ST depression in the 3 and AVF, once the summation of the ST depression, we expect ST depression. So once the summation of the depression in the 3 and AVF is greater than 2.5 small boxes, it's likely to be occlusion of the proximal LAD, that is before the first diagonal branch. However, once there is isoelectric ST segments in leads, or if there is ST elevation instead of ST depression, the occlusion is likely to be from the distal LAD material, because I just came across it too and thought I should share. Next slide, please. So echocardiographic localization of the coronary, the knowledge of coronary anatomy will also help in guiding us as to which vessel is occluded on echo. So as we can see on the apical four-chamber view. The anterior lateral wall, as we've mentioned, can be supplied by either the circumflex artery. So once there is segmental original wall motion involving the anterior lateral wall, it's likely to be the left LAD or LCX that is involved. Any regional wall motion defects seen along the right RV3 wall is likely to be RCA involvement. The same thing applies to the other views, short axis view, two-chamber view, and the apical three-chamber view. Next slide, please. So this is also showing us the coronary artery territory in relation to the 17 segments of the LV on echo. So it's color-coded, and then each segment is represented by the segments. Any regional wall motion defects along the side, it's likely to be right coronary artery involvement of the basal anterior septal region, and then the basal inferior septal region is likely to be due to left anterior descending artery occlusion, while if there is any problem along the basal anterior or basal anterolateral region, it's likely to be as a result of left circumflex artery occlusion. Next slide, please. Next slide, please. So for coronary venous anatomy, 85% of venous drainage of the heart usually is due to
you have 15 more minutes.
Sorry?
You have 15 more minutes.
I'm almost rounding up, sir.
All right, okay.
So the coronary sinus is a large venous structure that is located on heart, and almost all the cardiac veins drain into the coronary empties into the right atrium. So the tributaries, the major tributaries of the coronary sinus are the great cardiac vein. This is also known as it runs along with the left anterior descending artery and is the largest tributary of the coronary sinus. It's also originates from the apex and ascends into the anterior interventricular groove, just like the left anterior descending artery. And then eventually it's like a continuation of, it's continuous as the coronary sinus. The second tributary is, which also follows the course of the posterior descending artery. It's also known as the posterior interventricular vein. The small coronary artery, it's located, it courses along the posterior surface of the LV and eventually drains into the coronary sinus. We have the posterior cardiac veins, which also lie to the left of the oblique vein, which follows the posterior part of the left atrium. So we also have 15% of the venous drainage is via the anterior cardiac veins, which drain directly into the right atrium without branching to the coronary sinus. We also have small proportion of blood from the heart drained by the small veins of the heart, known as the Sebacean veins. These small veins are embedded deeply within the wall of the myocardium itself, and it drains directly into the for venous drainage of the heart is into the right atrium, with the left ventricle receiving least. Next. So this just diagrammatic venous drainage. This is the coronary sinus, which is the greatest of the cardiac veins drain into before eventually draining. The largest tributary is the great cardiac vein, and then the small cardiac vein. So we also have smaller veins which runs across the left atrium. And then we have smaller cardiac veins that are known as the cerebral into the myocardium itself without emptying into the coronary sinus. So basically this is the venous cardium. So I think with this, we've come to the end. Okay, this is just a sum discuss. The right coronary artery basically supplies the right atrium, SA node in 60% of cases and AV node in 90% of individuals. It also supplies the posterior part of the interventricular septum. And all these parts, all the myocardial parts drain directly into the small cardiac vein or the middle cardiac vein. The right ventricle and the apex are also supplied by the right marginal, acute right marginal branch of the right coronary artery, and they are drained by the small cardiac vein and the middle cardiac vein. We also have the posterior interventricular artery, which drains the posterior 1/3 of the interventricular septum. And this part is also, which is supplied by the posterior interventricular artery and drained by the left posterior ventricular vein. Then we have the left, next slide please, the left atrium, the major part of the left atrium, LV, and then the anterior third of the interventricular septum being supplied by the left coronary artery. And these areas are drained into the great cardiac vein before draining into the coronary sinus. Then the LAD also supplies part of the right ventricle, LV, and anterior 2/3 of the interventricular septum. And this part are drained also into the great cardiac vein. The left circumflex supplies the lateral, anterior lateral wall of the LV and the left atrium. And they are also drained by the great cardiac vein, all of which eventually drain into the coronary sinus and the right atrium. Next slide, please. Knowledge of coronary artery anatomy will also help us in coronary angiography. It will help in intervention. The different views on the views and how they are obtained. But basically, this is just an angiographic view outlining the right coronary artery here, and its branches, and this showing us the left coronary artery. This is the left main stem as it branches to form the left circumflex and then the left anterior descending branch. Other details on angiography and coronary, the different views I actually didn't understand. I don't know if it can shed more light on it. I think we've come to the end of the presentation. I'll entertain contributions and comments from senior colleagues and colleagues. Thank you. Hello.
Thank you so much, Dr. Zakia, for that beautiful presentation. Thank you for taking our time to prepare the slides. The floor is open for any questions and addition. Dr. Fatima, I beg, please. Oh, okay, Jacqueline is around. Okay. Please help me coordinate. I'm in a noisy place.
Okay, Chief Okopi. No problem. Any comment from the participants? Comment from the participants or questions? No question for Dr. Zakia?
Please, I have a question.
Okay, go ahead, please.
Thank you very much, Dr. Zakia, for a very beautiful presentation. I don't know if you can go over the infarct-related artery, territory you talked about earlier. I think in between, I wasn't hearing you at some point, so I didn't quite get that area clearly. I don't know if it's possible for you to go over that again. Thank you.
Dr. Zakia, did you hear that?
Yes, I heard him. I actually also got confused along the line when you mentioned V1. From the text I came across, in patients with inferior wall myocardial infarction, it's important to identify whether the inferior wall infarction is due to left circumflex artery occlusion or as a result of right coronary artery occlusion. So the first thing to do is to check the ST elevation in lead 2 and 3. Usually, if the ST elevation in lead 2 is greater than ST elevation in lead 3, it's likely to be due to left circumflex artery occlusion. However, if the ST elevation in lead 3 is greater than that in lead 2, it's likely to be due to right coronary artery occlusion. That's one. Then the next thing, if we want to actually check if the patient has RV wall infarction, inferior wall with RV wall infarction, then we'll check the right-sided lead. I actually thought we were supposed to check the right-sided lead. So in V4R is the most important lead, V4R and V3R. I used to know are the most important leads to check for the right RV infarction. So when we have ST elevation in lead V4R with an upright T wave, the occlusion is likely to be due to proximal RCA occlusion. But if the STL, if it's only upright T wave we have in V4R, it's likely to be due to distal RCA occlusion. But my chief mentioned something about the V1. I'm actually not very sure about it.
Yes, Dr. Zakia. ST elevation is in V1 is more specific for RV involvement than in V4R. That's what I used to know.
Okay. V1, okay. Okay.
Thank you
So
very much.
what I came across actually was that V1 is not specific for LAD occlusion, because the V1, sorry?
Yes, we are talking of RC occlusion affecting causing RV involvement.
Okay. Okay, okay. Okay, yes, I guess it.
Hello, Fatima.
Yes.
Hello, Fatima. We saw
Yes.
it in Brownwood. It's V4R that is more specific.
Okay, V4R is more specific for RCA occlusion than V1.
RV impaction, yes. V1, yes, yes. We saw it in Brownwood, one of the questions. Right?
Okay, what about
Yes,
the
it's
RCA occlusion?
V4R. It's V4R that is more specific for RV occlusion.
So any other question from the class? Dr. Zakia, I think you have done very well. There are no much questions for you. I don't know if the other presenter we have.
Hello?
Yeah, Dr. Godia, yes.
Yeah, sorry, I needed to, there's one or two things that I want to say. First and foremost, I want to appreciate Zakia for making our time to put up this beautiful presentation.
Thank you, sir.
There were some things that actually I would have loved that you include them in the slide, but they were somehow lacking. So I want to just comment a little on it. But first, the segmentation of the LAD actually is not sacrosanct that it has to be the first D1, or rather the branches of the artery that come off the LAD, irrespective of whether it is the septal perforator or the first diagonal branch that you were able to see, as long as there is a branch coming off it, that branch will be the that first branch artery will be the reference point for determining where the proximal part starts from. So for instance, if you have along the course of the LAD, a first branch is a septal perforator. You take from the beginning of the bifurcation or trifurcation of the left main, where is that's where the LAD starts from, to where that first branch originates from. That form the proximal part of it. Then from that first branch, either is the first diagonal or the first segmental to the next branch of either diagonal branch or a septal perforator. That second branch, from the first to the second branch, form the middle segment. Then from there up to the end of the LAD is the distal portion. And also, the length of this LAD varies in individuals. You have individuals that the length of the LAD stop short before the apex of the heart. So if you have such an LAD, it is classified as a type 1 LAD. Then there are individuals that the LAD goes down to the tip of the apex, and that is usually classified as type 2 LAD. Then there are some that the LAD will go beyond the apex of the heart and even cross toward the posterior interventricular groove. That is known as the wrap around LAD, and that is the type 2, or rather type 3 LAD supply. So, and it's also suffice to mention that this LAD is very important because it supplies the vast portion of the heart, the left ventricle in particular. So, occlusion of this LAD is usually very fatal, more especially if it happened at the proximal part. And it has been termed as the widowmaker artery in most books. You see, they will say is widowmaker artery. And again, I want to correct a notion or an assertion that we made that obtuse marginal are 3 in number. It is not correct in the sense that there are a lot of variation. The numbers of obtuse marginal may be as short as 2, or however, it can be as many as possible. There is no particular number that will say that the obtuse marginal in a particular individual can branch. You can have as much as up to 5 or 6 obtuse marginal emanating from the circumflex artery. So also, in trying to discuss this anatomic variation or anatomical abnormalities, it would be safe actually if you had classified it as variation that occur from the origin of these coronary arteries. You know, there are other abnormalities of origin that you did not mention, like the anomalous right coronary artery.
Okay, yes, sir.
Yeah, and also anomalous left coronary artery, or anomalous origin of the coronary artery from the aorta itself. The aorta, the coronary artery can originate from the aorta, but in an abnormal position. Like for instance, the right coronary artery can originate from the left coronary sinus as well. And also likewise, the left can originate from the right. And they can also originate from other points on the aorta, not like it's not sacrosanct that be from there, and all of them, yes, they have clinical significance. So also there are abnormalities that occur when the coronary artery are coursing. That is abnormality of the course of the coronary artery. You know, normally the coronary artery are expected to course along the epicardial, that's beneath the epicardial fats. But you find situation whereby some of these coronary artery can be buried deep within the muscles of the that's the myocardium, and they're usually termed bridging bridging vessels. So this also have clinical relevance when you are discussing the coronary circulation. Then there are abnormalities that occur at the ending where the coronary arteries are supposed to end. Usually a normal artery end into arterioles and then capillaries, and then it forms venous. The venous will now drain either into the coronary the coronary sinus, or they may drain directly into the chambers through the venae cordis minimi, which you term as the Bayesian veins. So that is the normal. Uh, uh, that is how the coronary arteries and should normally terminate. But you find situation whereby instead of the coronary artery to terminate as capillaries, for instance, they cross directly and form a connection between the coronary arteries and the chambers. It's the heart chambers itself, either on the left or on the right. Commonly, usually on the right. So if that occur, it causes what is known as the coronary camera fistulae. So, and in this, it has also clinical significance because usually, just like normal flow that happens in vessels and in any other tube, whenever there is a tube that has a lesser resistance, the flow of blood tend to go through those, or the flow of fluid tend to go through tend to be redistributed through the chambers that have lesser resistance, and thereby depriving those with higher resistance of flow. So in such situation, the individual that have this coronary camera fistula, they can actually come with symptoms that mimic myocardial infarction and the rest. Then the coronary arteries also may end up forming a fistula or anastomose, or directly draining into either the pulmonary trunk, or direct into the coronary sinus drainage, and that will form a arteriovenous kind of fistula, and that is also they have clinical relevance. So, and also what I needed to draw your attention about the clinical significance of this coronary sinus is that, you know, that coronary sinus is used mainly by by electrophysiologists a lot in placing leads. For instance, when you are doing CRT, which of the vein do you put your the left chamber lead in? Because you in CRT, the lead to the left ventricle is not put into the left ventricle, but it's usually passed through the coronary sinus and into this middle cardiac vein, which I heard you, whether it was by mistake, erroneously said that it courses along the posterior descending artery. It's actually the small cardiac vein that courses along the posterior descending artery in most almost all individuals. So that middle cardiac vein actually courses along the surface of the left ventricle, and that is the vessel that is usually targeted when you are trying to do or to insert the left ventricular lead during CRT. And okay, I think I have talked a lot, so let me allow other people also to make contribution. Thank you very much for
Thank you
the
very much, sir. Thank you, sir, for the contribution. Sorry, this thing on CRT is not very clear. The explanation you gave on the middle cardiac vein is used when catheterizing.
Yeah, it's not catheterization, it's insertion of the lead. You know, the lead is, you are putting the lead into a vein that lies directly or directly on the left ventricle, because that is where you want to pace. Do you understand? The coronary the coronary sinus, just as we have tried to discuss, have a lot of tributaries that drain into it. So the great cardiac vein drain into it. Then we now have other vessels that are draining into it. That is this middle cardiac vein also drain into it. And we also have the oblique veins, which is also called the vein of Marshall, and it's like a remnant of the right, sorry, the left anterior cardinal vein that was supposed to form what is known as the left superior vena cava. But during development, that the superior part of that left superior vena cava have a direct connection with the right, and that is why it formed like a right subclavian vein, and then the remnant of the stock of what is left of it is what eventually formed that the oblique vein that is drained into the coronary sinus. So there could be some anatomical variation also, where this particular vein will persist, and instead of the connection and reconnection of the superior, the right sub the, the right subclavian vein to reconnect with the left, with the right the left subclavian vein, failure of its connection with the right subclavian vein to form the superior vena cava may give a situation whereby you have like a two superior vena cavae, but the one on the left will drain directly into the coronary sinus, and that is known as the left superior vena cava. And in this situation, when you are doing, it also have relevance, because when you are trying to insert a pacemaker device, for instance, or a CRT, and you use the right side, you find it difficult to connect to the right atrium and the right ventricle. So those are the significance of these vessels. So what I'm saying is that the one that lie like directly over the right, the left ventricle is that middle vein. And even in one of the pictures that you showed on the venous drainage, you will see that the middle, the small cardiac vein is actually the one that comes along with the
Descending artery.
descending artery.
Yes,
so
sir.
that is Just what I was trying to clarify.
Okay, thank you very much, sir. Thank you very much.
Dr. Goodyear, I bow for you, sir. Thank you so much, sir, for all this wonderful contribution. The professor of the PR segment of the ECG. Thank you, sir. Dr. Fatima, just let me tell Professor, thank you. Over to you, man.
Yeah, well done. I think my network went off. I was not even hearing you. So I don't know if there is any comment from the class again. Any comment from the participants, please? So in the absence of no comment, Dr. Philothea will be presenting next. Dr. Philothea, are you ready? Dr. Philothea.
I think Dr. Philothea may not be ready.
Okay.
Yeah, she sent me a chat. She's quite engaged, so she will do it on Tuesday.
Okay.
And she took permission. I don't know, but she's on the call. I don't know if she came back. Dr. Philothea, are you ready? I don't think she's ready. She was on the call.
So it means we have to call it a day, right?
Yes, Dr. Godia will be taking a pacemaker again on Monday.
Okay, okay. So
Please,
that's good.
Let's not miss it, too, because just the way you see him talking like this, Monday will be the same thing. Yeah.
All right.
Thank you so much.
So thank you very much. Yeah. Dr. Okobi, you can close the class.
Sorry, you said what?
You can close the class for us. You are the chief now.
All right, everyone, thank you so much for coming for today's class. I want to thank Dr. Zakia for taking our time to make tonight's presentation. I also thank Dr. Goodyear for the professorial contribution. Thank you, everyone. Thank you, Dr. Jacqueline. Thank you, Alex Itubi, for sharing the slides. So we'll see you on Monday then. Please have a good evening. Tomorrow, and Professor Ladimeji will be giving his talk on PCI. So please, let's be there by 6 p.m. Thank you.
Yeah,
All right.
thank you. Bye.